Dear doctors, in this video, I am going to discuss questions related to EDIC Part 1 with their answers and explanation. In today's video, I will discuss questions related to cardiology section. Let's move on.
Question 1. A 65-year-old man with septic shock on norepinephrine develops new-onset atrial fibrillation with a heart rate of 150 per minute. His mean arterial pressure is 68 millimeters of mercury, lactate is 3.2 millimoles per liter, and echocardiography shows hyperdynamic LV function. Which of the following is the most appropriate next step? Initiate intravenous amiodarone loading followed by infusion. B. Perform synchronized electrical cardioversion immediately. C. Administer digoxin intravenously. D. Increase norepinephrine to maintain higher MAP. Start esmolol infusion after optimizing volume status. Correct answer is E. Start esmolol infusion after optimizing volume status. Explanation. In septic shock, new atrial fibrillation is often catecholamine mediated. If LV function is preserved and MAP acceptable, short-acting beta blocker, esmolol, is preferred to control heart rate and reduce oxygen demand. Amiodarone is reserved if beta blocker contraindicated or ineffective. Electrical cardioversion is rarely effective until sepsis is controlled. Question 2. A 55-year-old woman with decompensated heart failure is admitted to ICU. Pulmonary artery catheter shows right atrial pressure 14 millimeters of mercury, pulmonary artery pressure 40/25 millimeter of mercury, PCWP 24 millimeters of mercury, cardiac output 3.2 liters per minute, SVR 1500 dynes, SCM. Which of the following interventions is most appropriate? Start norepinephrine infusion. B. Administer furosemide and start nitroglycerin infusion. C. Begin dobutamine infusion. D. Restrict fluids and add phenylephrine. Perform ultrafiltration immediately. Correct answer is B. Administer furosemide and start nitroglycerin infusion. Explanation. High filling pressures, low cardiac output, high SVR suggests wet and cold heart failure. First line, reduce preload and afterload, diuretics plus nitrates. Inotropes are reserved for persistent hypoperfusion despite optimization. Question 3. During post-cardiac arrest care, a patient remains comatose. Continuous ECG shows ST elevation in AVR with widespread ST depression in inferolateral leads. Troponin is elevated. Which coronary lesion is most likely responsible? Occlusion of LAD. B. Occlusion of left circumflex artery. C. Occlusion of right coronary artery. D. Left main coronary artery occlusion. E. Posterior descending artery occlusion. Correct answer is D. Left main coronary artery occlusion. Explanation. ST elevation in AVR with diffuse ST depression indicates global subendocardial ischemia, classically due to left main or severe triple vessel disease. Urgent coronary angiography is indicated. Question 4. A 70-year-old man with anterior STEMI develops hypotension, beep 80/60 mmHg, after reperfusion. Echocardiography shows LVEF 30%, no tamponade, normal RV, PCWP 26 millimeters of mercury, cardiac index 1.9 liters per minute per square meter. Optimal management includes: add norepinephrine and intravenous fluids. B. Start levosimendan infusion. C. Insert intra-aortic balloon pump. D. Begin high-dose vasopressin. E. Give intravenous metoprolol to reduce arrhythmia risk. Correct answer is C. Insert intra-aortic balloon pump. Explanation. Cardiogenic shock post-MI with high filling pressures and low cardiac index requires mechanical support. IABP reduces afterload and improves coronary perfusion. Levosimendan may help later but not first line. Vasopressin and fluids worsen congestion. Question 5. A 58-year-old man with COPD and chronic AF is admitted with septic shock. His arterial waveform shows a pulsus alternans pattern. This most likely indicates aortic regurgitation. B. Severe LV systolic dysfunction. C. Pericardial tamponade. D. Severe hypovolemia. D. Aortic dissection. Correct answer is B. Severe LV systolic dysfunction. Explanation. Pulsus alternans, beat-to-beat variation in systolic pressure with regular rhythm, indicates severe LV failure with alternating contractile strength, seen in advanced cardiomyopathy or ischemia. Question 6. In a patient with acute inferior MI, the following hemodynamic findings are noted: CVP 15 mm of mercury, PCWP 8 mm of mercury, cardiac output 3.5 liters per minute. Which is the most likely complication? Papillary muscle rupture. B. LV free wall rupture. C. Right ventricular infarction. D. Ventricular septal rupture. Acute mitral regurgitation. Correct answer is C. Right ventricular infarction. Explanation. High CVP with low PCWP and reduced cardiac output suggests RV infarction, preload dependent. Management. Cautious fluid loading, avoid nitrates and diuretics. Question 7. A patient in ICU develops polymorphic VT, torsades de pointes, while on amiodarone and ciprofloxacin. ECG shows QTC 540 milliseconds. Which of the following is the most appropriate initial step? Defibrillate immediately. B. Give intravenous magnesium sulfate. C. Administer amiodarone bolus. D. Perform transcutaneous pacing at 60 bpm. E. Infuse lidocaine. Correct answer is B. Give intravenous magnesium sulfate. Explanation. Torsades de pointes due to QT prolongation treat with intravenous magnesium, even if normal magnesium levels. Increase heart rate if recurrent by overdrive pacing or isoproternol. Avoid further QT prolonging drugs. Question 8. A 68-year-old man is 6 hours post-CAB. He becomes hypotensive, BP 80/50 mmHg, with rising chest tube drainage of 250 milliliters in the last 30 minutes. CVP is 8 mm of mercury, PCWP 10 mm of mercury, and cardiac index 1.7 liters per minute per square meter. Heart sounds are muffled, and there is poor response to fluids and inotropes. What is the most likely diagnosis? Right ventricular failure due to ischemia. B. Hypovolemia from ongoing bleeding. C. Cardiac tamponade due to pericardial clot. D. Graft occlusion with LV infarction. Protamine-induced pulmonary hypertension. Correct answer is C. Cardiac tamponade due to pericardial clot. Explanation. Early post-CAB tamponade may occur without classical equalization of pressures because of localized clot or posterior effusion. The key features are rising drainage, hypotension, low cardiac index, and muffled heart sounds. Question 9. A 59-year-old hypertensive man presents with acute tearing chest pain radiating to the back. CT confirms Stanford type A aortic dissection. While awaiting surgery, BP is 170 by 95 mm of mercury, heart rate 105 bpm. Which of the following is the most appropriate immediate management? Start nitroprusside infusion alone to rapidly reduce BP. B. Begin esmolol infusion followed by nitroprusside if required. C. Start hydralazine to reduce afterload. D. Initiate norepinephrine to maintain perfusion. Begin labetalol bolus without continuous monitoring. Correct answer is B. Begin esmolol infusion followed by nitroprusside if required. Explanation. Goal in type A dissection: reduce aortic shear stress, decrease heart rate less than 60 per minute, reduce systolic BP below 120 mm of mercury. Beta blocker first, esmolol or labetalol, to reduce DPDT means rate of rise in pressure. After heart rate control, nitroprusside may be added for BP. Vasodilator alone worsens shear stress due to reflex tachycardia. Norepinephrine and hydralazine contraindicated. Question 10. A 67-year-old man develops new-onset atrial fibrillation with heart rate 130 per minute on day 2 after CAP. He is hemodynamically stable, BP 110 to 70 millimeters of mercury, saturation 96%. Electrolytes are normal, and echo shows preserved LV function. Which management is most appropriate initially? Immediate synchronized cardioversion. B. Intravenous imiodoron bolus followed by infusion. C. Start beta blocker metoprolol for rate control. D. Begin digoxin loading. Observe without treatment. Correct answer is C. Start beta blocker metoprolol for rate control. Explanation. Postoperative AF is common, 20 to 40%, after CAB due to atrial irritation, inflammation, and catecholamine surge. First-line therapy, beta blockers to control rate and reduce recurrence. Amiodaron reserved if rate control fails or LV dysfunction present. Electrical cardioversion only if unstable. Digoxin less effective post-CAB due to high sympathetic tone. Observation alone risks thromboembolism and hemodynamic instability.
Dear doctors, dear experts, if you have any questions, please write down in the comment section for me to respond. See you in my next video with more questions for EDIC Part 1. Till then, bye and take care.